Thanks, Alan, and welcome everybody, and welcome all of you guys watching us on TV. I'm going to be as brief as I can, but I'm super excited to introduce Sharon Chen, who's my colleague and my friend of many, many years. And Sharon is known in our division as the master clinician. I can't tell how many times I've heard the phrase, let's ask Sharon. And so she has built this reputation for her clinical and her critical thinking that all of you probably know about on the wards. But she's also an amazing educator. And I had the pleasure of working with her for 10 years, teaching over 1,000 medical students and developing new ways of teaching. And Sharon, I realized, working with her very closely, that she's not just a teacher, she's a learner. And she's such a learner that she was teaching me about pedagogy and all of these strange literature that she was reading in education. And I realized that about 6 or 7 years ago, she paired with another of the mentors, educator mentors that I cherish, is Kathleen Gutierrez, who's here today, who I actually gave the Fuji Apple Award when I was a fellow. And they started, thinking together about, can we figure out how experts think? And they started this project, and they went to the Department of Education in the school. They paired up with a physics Nobel laureate and a bunch of computer people and a bunch of education people. And now their team has grown to be part of the medical school digital education projects. And what she's going to talk about today has the title AI in it, but I don't want to give it all up, but you're going to be surprised because it's not what you think. The first time I heard the term AI, artificial intelligence, I thought that's the best description of an oxymoron I've ever heard. And she's proving us wrong because she took the AI and turned it upside down. And what I mean by that is, instead of making something that thinks for us or makes us think less, she created a tool, she and her team created a tool that is going to help us see how we think and think more and think better, perhaps. So with that, I leave it to Sharon and her team to tell us about it.
I have fond memories of that. It's been really fun. So good morning. First, I want to thank the Grand Rounds Committee for inviting me and our entire team to share with you about our work. And we're just so excited to talk about AI Clinical Coach. So this is an education tool that we have created to foster these thinking habits for clinical medicine. Sorry, it went, how do I go back one? It went forward before I wanted it to go forward. Okay, I tried it. Okay, thank you. So this is an education tool that we have created to foster these thinking habits in clinical medicine through AI augmented learning. And this is what I hope you will learn today, to articulate why reflection practices and problem solving is key to training physicians for the future, to describe how the thinking habits matrix provides a framework for problem solving in patient care, and to explain how AI Clinical Coach is an example of using AI to augment teachers, not automation or replacement, and explore ways of implementing AI Clinical Coach in your practice. All right. Building this tool takes multiple disciplines. And so what I'd like to begin with is to introduce you to the AI Clinical Coach team. First of all, Manuel already talked about Kathleen Gutierrez. She is an emeritus associate professor of pediatrics. She is the one that trained me, trained Manuel, and trained Lisa, trained everybody. And I mean, truly, Kathleen is one of the best thinkers I've ever had the privilege to work with. And for our project, she serves as our expert of critical thinking as it applies to making good patient care decisions. The second person up here is Shima Salehi. She is an assistant professor in the Graduate School of Education. Her expertise is in reflection practices for problem solving, and this is in higher education of STEM fields. She also is an expert at education pedagogy, and we lean on her for those education expertise. Shima and I actually met in the lab of Dr. Carl Wyman. This is the Nobel laureate physicist that Manuel mentioned. Later in life, he actually pivoted over to try and improve STEM education, and it's why we were very lucky to be able to work with him. The next three members of the team are part of a group called Education Technology. And just as it sounds, they sit on the crossroads of education and technology, and they serve the School of Medicine and the hospitals. William Bottini is the creative director for EdTech, and he serves in that role for our project, and he's also our expert at the prompt engineering. Tila Call, unfortunately, was not able to make it today, but she is the learning technology team lead for EdTech, and she serves as our project manager and the curriculum director for the study that we are running. And Peter Nguyen is our leading innovation lead for EdTech, and he serves in that role for our project as the innovations expert and our liaison for product development. So today, you're not just going to hear from me, you're going to hear from all of the team members as we tell you about AI Clinical Coach. So to frame the mindset for this particular talk, I have two questions for you first. Okay, so this is a PollEV question. If you can scan the QR code to log into it. And here is the question for you. In one word, what aspect of your work as a teacher and or physician can never be replaced by AI? Give you some time. These are great. I saw nothing. This is wonderful. You know, we did this particular exercise as a team, and so many of these words were ones that we came up with, and this is really, really lovely. Peter, I can just move forward and then, right, okay. Oh, and then that's my timer. Okay, so great. Okay, now for the second question. Okay, so this one takes a little bit of explaining. There's no PollEV on this one. You don't need to share, just do it in your head. All right, and think of the first question that comes up. I know, you guys are all ready. Lisa was like, I'm ready. What's the next PollEV question? Okay, no, this one, just do it in your head. I don't need you to share. But please do it, because I come back to it. And I want to set it up for the scenario. So think of a small problem that you've had at home, small, all right? So maybe the toilet didn't flush, all right? Maybe you were really jazzed about making cookies and there's no eggs in the refrigerator. Maybe you went into the room, you turned the light switch on and the lights didn't come on. So what was that first question that you asked yourself as you were solving that problem? I'll give you 20 seconds to think about that. Keep that question in mind as we go through the next several slides, right? You all know we are living in a rapid evolution of generative AI. It's clearly caught my attention, and it's forced me to do a lot of reflection. And the end result is this. We are currently still living in a knowledge mindset. And what we need is to start cultivating a thinking mindset in order to keep up with AI evolution. In order to do that, we need something new. And that is why we have created AI Clinical Coach. So I'm going to give you a sneak peek in the next several slides of what AI Clinical Coach is, and then we're going to go back to the beginning of how we developed it. AI Clinical Coach consists of two components. One is a problem-solving framework. This is what we call the Thinking Habits Matrix, and it's adapted to and enhanced by AI functionality in a mobile device. All right, you'll hear me talk about AI Clinical Coach by its nickname, AI Click. So the problem-solving framework we call the Thinking Habits Matrix, or THM for short. And you can see it consists of 6 different elements. And think back at that question that you pose to yourself when you're solving that small problem at home. Maybe you recognize some of these words in that particular question. So we created this phrase, thinking habits, to encompass many aspects of critical thinking, self-regulation, metacognition, among others. We also are very intentional about using the word habits because in the end, we want people to make this type of thinking a habit. In each of those thinking habits elements, we have listed out a few self-reflective questions. You can see them in the 6 buckets. So for example, under problem definition, is this the most important problem to solve? Or in interpretation, is this what I expected? And you can also see that these have been translated more for the problems we solve, which are patient cases. And when you read through these questions, think back at that question you posed to yourself when you're solving your small home problem. Perhaps they are similar. Thinking habits is not the same thing as clinical reasoning. There is overlap. And so you will see some of those familiar clinical reasoning words down on the bottom in the light purple. So as I said, the THM is adapted to and enhanced by AI functionality. AI Click listens to case presentations between you and the trainee using a simple web-based application that's secured in REDCap. It provides reflective questions using the Thinking Habits Matrix that I showed you, and it's fine-tuned on prompts on those 6 THM elements. It facilitates teacher and trainee conversations by providing a personalized self-reflective question about your trainees' thinking habits. And lastly, it tracks thinking habits over time so that both the learner and the teacher can analyze growth of learning over time across all 6 THM elements. Here's a photo of Kathleen and I using AI Clinical Coach. We're actually talking about one of the suggested self-reflective questions that the bot gave us. And here are some snapshots of the user interface. It is a mobile application. and you record with your phone. You can also access the report, the Thinking Habits Matrix report, on your phone. We specifically built AI Clinical Coach so that you can easily use this in the hospital, in the clinics, as you do your everyday work, taking care of patients. So now that I've given you the sneak peek of AI Clinical Coach, what I'd like for us to do is go back to the beginning of how we created the THM and how we created AI Clinical Coach. And I'd like to invite Shima to help us learn.
Okay, let's see. Yes, it's working. First, good morning and thanks for having me. And I am so glad to be among a group of pediatricians, and that fulfilled my mom's dream of me becoming a real doctor, because she never believes in education being really doctor. But as Manuel alluded to it earlier, I am one of the School of Education people, and my research is about looking at how we can teach complex problem solving more effectively in science and engineering, and more recently, thanks to the team, in medicine and medical education. But what we talk about when we talk about complex problem solving? With Carr, the physics laureate, and the team during my PhD, we look at what are the main practices one engaging to solve complex problems in different fields of science and engineering. And universally, across all these fields, we identify 29 practices. And we publish it. You can also see a picture of it here. But then I got to know Sharon. And thanks to Sharon, we started thinking, okay, how many of those practices are really applicable in the context of patient care? So we started this translational work of taking those practices and see what they look like in the context of patient care. And that work was not only possible thanks to Sharon and Kathleen being a critical thinker, but also to my PhD student who did his MD, but now doing a PhD in a School of Education. So we adapted, and interestingly, all those 29 practices were applicable to the context of patient care. But more interestingly was reflective practices. And this work highlighted the importance of reflective practices. But what do I talk about when I talk about reflection practices? What are those? The reflection practices are the practices that one engage in during problem solving to make intentional and informed decisions. Intentional meaning that they acknowledge there is a decision to be made, deciding whether X-ray or fMRI to conduct. And informed meaning that they consider different options, and based on the pros and cons of each option, they decided what is the most effective one to take to decide and choose in the given context. Now it's actually more than a decade-long research, we identified reflective practices is the secret sauce of adaptive problem solving, which is expertise of applying knowledge to the context of new problems. What we saw is that if we have problem solvers who are taught particularly reflective practices as they engage in problem solving, as seen in green in this graph, they outperform significantly compared to problem solvers who do not know about reflective practices, but they just solve more problems. So despite solving more problems, the orange line underperformed to the problem solver who learn about reflective practices because they know how to better reflect during problem solving. Interestingly, what we identified as reflection practices in the context of science and engineering problem solving was very similar to the question that Kathleen and Sharon developed during years of taking care of complex patient cares. And that was, for me, another evidence that reflection practices is really that secret sauce. And it's important also in the context of patient care. So with the team, we decided to focus on the manifestation of reflection practices in the context of patient care. And that led to the development of what Sharon earlier introduced as thinking habit matrix. thinking habit matrix, or at least aspects of it, have been alluded as important skill in other works, but of course referred with different terminologies such as self-regulation and critical thinking. But once more, let's look at why thinking habit matrix, or as short THM, is important in the context of patient care. Kathleen.
So it's really wonderful to see all of you and to see so many familiar and friendly faces. So welcome. So, you. So in my many years as an ID physician, our team was often confronted with confounding and complex patient problems to solve. And sometimes the answer would be straightforward. And sometimes there was a lot of uncertainty and a lot of complexity. And we had to do a lot of thinking about what might be the best solution for best to care for our patients. And so over the past few years, it has been my privilege to work with this wonderful team and to try to have a better understanding of how it is that all of you as experts solve complicated patient problems. Knowledge obviously is important in patient care, but how we think about that knowledge and how we utilize it wisely is absolutely critical, especially now in the days of AI. The reflection practices that are embedded in this thinking habits matrix offer guidance and offer a shared language to optimize our thinking habits as well as the thinking habits of those we teach. Other individuals have also noted in recent publications the importance of critical thinking in medical training. And so this paper is a study that was put together by a group of French medical educators during the COVID era, when they noticed that there was a lot of knowledge that was available online, but not all of it was reliable knowledge. And so they felt that they needed to get a better understanding of how to teach their learners, how to teach their young doctors how to think critically. And so they began this process by embarking on a literature review. They actually looked at hundreds of papers in the medical education literature. And they found that medical educators felt that critical thinking was crucial, but that it was not really explicitly taught in healthcare curriculum, and that validated tools for student empowerment was essential. More recently, a group of researchers in Harvard decided to look at this question about critical thinking in education as well. And this team of researchers was interesting. They were comprised of individuals, a couple of whom were critical care physicians. And what they did was they developed a survey, and they asked their faculty in the departments of medicine, education, and government to define what they thought critical thinking was. What is one word that defines critical thinking? And you can see that the faculty definitions actually kind of reflect what you see in Bloom's taxonomy. They said that analysis was an important component of critical thinking. So how do you analyze the information that you are given? How do you evaluate the information that you were given? When they posed that same question to the students of this faculty, students said that they thought that critical thinking was what are my biases? What are my assumptions? What are the nuances of the data that I'm reading? So you can see that there was a disconnect in the definition of critical thinking between faculty members and their students. So a second question that was posed in this study was, is critical thinking explicitly taught in your classes and in your curricula? And the faculty said, the majority of faculty said, yeah, we think that we explicitly teach critical thinking. We do so by posing questions or asking our students to do reflective writing. When the students were asked that same question, have you explicitly been taught how to think? The students said, no, we didn't learn how to think. We just implicitly figured things out by observing faculty and role models that we thought were good thinkers and that we admired. So you can see that there is not a shared language between us as teachers and our learners. So why is that? So barriers to teaching critical thinking. So first of all, we all tend to default to this knowledge mindset. So we evaluate our learners by their test scores or the knowledge that they're able to access or retain, but not how they actually use that knowledge. As I said before, we don't really have a common language or a shared mental model of what it means to have a reflective practice or think critically. We as educators are not taught. We aren't guided on how to teach. I used to think that I maybe taught my learners how to think critically, but now I know I probably didn't do that explicitly. There's inconsistent assessment and lack of longitudinal evaluation of thinking skills. And so we hope that, by developing this mental model, this thinking habits matrix, that will alleviate some of those barriers. And finally, there's clinician time constraints. You all are busy with clinical care, with research, with administrative duties, and with teaching. And how do you find time to be able to coach your learners and your trainees in critical thinking? And we hope that AI Clinical Coach can help with those time constraints. So we developed the THM in part based on our own experiences, but also in interviews with experts, some of you who are in the room, by our collaboration with Dr. Salehi's team, and by our own research into metacognition and into critical thinking. And now Sharon is going to update you and give you some information about the work that we've been doing and the research project that we are undertaking.
Thank you, Kathleen. Okay, so as Kathleen said, excuse me, we are running a study right now, and I want to begin before giving you some data to just tell you two study approach concepts that are important just to frame this particular study. The first is that our study participants are co-creators of this research rather than objects of the study. We have this amazing group of attending physicians who are study participants right now, and they are conducting a participatory research with us. We are approaching the study with a constructivist worldview. The second important study approach concept is based on the learning theory of deliberate practice. So learning the THM and learning AI Clinical Coach is a complex skill. And based on deliberate practice, we have broken that complex skill into sub-skills, which then we allow our participants to deliberately practice in workshops. And to the right, you can see a little snapshot of the curriculum that we use in our workshop. So for the next several slides, I'm going to give you some examples of these sub-skills and the data from it. One of the first sub-skills is to actually learn the language. So our study participants are very experienced attending physicians. I am sure that they are using many of these thinking habits. What they may have trouble with is articulating those thinking habits out loud. And you need to have language. So this type of language will help. The second thing is Kathleen and I created a lot of this language that you see on this card. And we really needed to know if our colleagues could even comprehend what we were writing. So one of the activities we gave to our study participants in the workshop is for them to create new self-reflective questions. And in the yellow highlight are 3 examples of brand new ones. These are not ones that Kathleen and I created. And these were created by our study participants. And in fact, we have included them in the newest iteration of this THM card. If you're interested, we have some in the back. All right. From looking at these particular questions that our study participants have created, we felt like these were very meaningful and concluded that our study participants did actually comprehend our THM language, and we're very happy about that. So in order to learn and adopt the THM, it's not just about language, but it's also, about integrating that concept so that it's easier to adopt using the THM. So to practice this particular subskill of adoption, Kathleen and I created a whole bunch of small vignettes. And you see one here, and we used contrasting cases. And in this particular vignette, we targeted one particular thinking habit, all right? And I'll just zoom in a little bit so you can read. The 2-year-old with croup is the vignette. And the parents are really scared that he's going to stop breathing. But actually he's playing and his oxygen saturations are fine. So in scenario A, the learner is recognizing that the parents need someone to acknowledge and allay their fears, but he doesn't feel like he has the skills. Whereas in B scenario, the learner is basically not recognizing the parent's perspective, right? And is just becoming defensive. So we were targeting the thinking habits of frames of mind in this particular vignette. And that's what we wanted our study participants to be able to figure out. So they did. They actually did say, oh yeah, this looks like frames of mind. But they also said, and it looks like there's aspects of problem definition, and there looks like there's aspects of solution. And they gave us, Kathleen and I, very good rationales for it. We had this really robust discussion about this vignette and many others. And so after we did several of these small little vignettes, we observed a couple of things. One is that clearly our study participants were adopting the THM. We could tell from the discussions. Second, we realized that the THM actually enables flexibility and enables conversation. We had lots of that. And both of those are so important for coaching and for learning. All right, so after learning the language and adopting the thinking habits, what we wanted to now look at is what happens when these study participants take that THM and go out in the real world. How do they use it? Where do they use it? When do they use it? And so I'm just going to show you a few pieces of data from how they've taken it out into the real world. First, somewhat expectedly, we saw that they targeted the THM element of solution quite a bit, but we are happy to see that they worked on all 6 of the THM elements with either a learner, or sometimes they did self-reflection and used the THM on themselves. They had many positive comments. So having a common language for the trainee and for themselves when they did self-reflection was key for all of them. All the study participants actually said the coaching took less than 5 minutes. This was not a long drawn out thing. And in fact, one study participant said their trainee quickly adopted the THM language and actually used the THM language to ask for feedback through the week. Of course, there are challenges. These attending physicians it hasn't become a habit to use the thinking habits matrix yet. So they need reminders to use it. We had lots of discussions, and they came up with very many different scenarios of where do you fit in using the THM or coaching into your everyday work. And lastly, how do we quickly explain the THM to trainees, because it's not a ubiquitous tool yet. And we had many good ideas, but all of this is a work in progress still. So our study is still ongoing, so I don't have a whole lot of data to tell you about impact, but I thought I would share our theoretical framework. And that is, if we can, and when we can make use of THM a habit, then we will have experts who can solve any new problem in the future, any kind of problem, any kind of patient case. And that results in all of us, attendings, trainees, any healthcare provider, to then make better patient care decisions. We hope the outcome of all of this is that we enable all of us to have more effective patient care and potentially decrease harm to our patients and decrease costs. So I've talked a lot about the THM, and in fact, you can just use the THM as is. So why would we need AI? Because AI helps us humans relieve that cognitive load, and it enables longitudinal tracking, right? So let me just give you some examples. First of all, humans cannot deal with all 6 of those THM elements at once, but AI can, right? Humans really do not have limitless memory, but AI does. And humans will find it easier to adapt an AI proposed coaching question instead of creating it de novo. So this is why we think it's important to have an AI adaptation. And I'm going to invite William to up here to give us more details about AI clinical coach.
Thank you, Sharon. All right, happy to be here. And I'm going to show a brief video, a role play demonstration of how an attending and trainee might use the THM and AI Click.
Okay, Sharon, let's start. And we talked yesterday about using AI clinical coach today. Are you okay with that?
Yes, absolutely. Thank you.
I'm hitting record.
Okay, so this patient is a 3-day-old full-term infant born to a 32-year-old G1P1 via normal spontaneous vaginal delivery, no complications. Mother had no problems during pregnancy. Prenatal care was complete. The baby developed a fever yesterday. No other signs or symptoms with it. So we drew a blood culture, we did an LP, and then sent off a CSF culture, and then we started ampicillin and gentamicin. This morning, he seems clinically okay. He doesn't look sick. He's starting to breastfeed a little bit. There's no more fevers. The vital signs seem normal for age. The blood culture came back positive for Canada. So I already ordered repeat blood cultures, an ophthalmology exam, an echocardiogram, abdominal ultrasound, and immune studies. My plan is to start fluconazole. So what do you think? What else should I do?
Sharon, I'm going to stop recording now.
Okay, thank you.
Yesterday, when you drew the blood culture, did you think about what result you might expect from that blood culture?
Not really. I mean, I guess bacteria, but when I saw Canada, I was pretty worried. They can be pretty serious in newborns, so I thought I'd better do a dissemination workup and start treatment. So I talked to the lab, and they told me that the baby does not have Canada. The blood culture is actually negative so far. How did you know to double check?
Well, Sharon, I asked you to call the lab and double check the blood culture because the story didn't fit with the new finding of Canada. So let me show you. When I'm trying to solve a patient problem, I try to remember to use the elements in the thinking habits matrix when I think about a patient. So what I did was self-reflect on the new data that you gave me.
So if I had asked myself, what do I expect when I got that blood culture? Then with the Canada result, I might have thought that that was kind of odd because I was actually expecting bacteria, right?
That's correct. And you might have at least paused.
Yeah.
Or you could maybe have called to ask me to discuss the case.
Right.
But instead, you assumed that the Candida finding and the blood culture was real, and you proceeded to plan a lot of interventions. That's a big deal for a 3-day-old baby and his parents.
It's true.
Here is the clinical coach report. The bot gave you several suggestions of things to work on. I agree with the bot that some work on self reflection, on interpretation would be good. Okay. And it also suggests working on self reflection on solution. And I agree.
Yeah.
Okay. So for the remaining patients today, I would like you to ask yourself, what do I expect each time you order a test? And when you present the next patient cases, I would like to hear what you expect. What do you think about that?
Yeah,
Do you think you can do that?
I think I can definitely try.
Okay, great. Did you see a new patient?
I did. Okay, so this patient is a previously healthy 5-year-old. He's got 5 days of knee pain and it's getting worse. He won't walk anymore. I think what I'd like to do is get a blood culture, and I'm expecting to find bacterial growth in this culture because that would be the most common cause of a joint infection. But for treatment,
Wait, Sharon, let me stop you there. I just wanted to let you know that I noticed that you articulated your expectations for the tests you ordered, and you did it without any reminding or prompting from me. And it looks like it's starting to become a habit.
All right, thank you, Sharon and Kathleen, for that great performance. So I'm going to walk through a little bit of how AI Clinical Coach works now. The first thing that you saw is that the attending started a new coaching session with a trainee and began recording the conversation on their device. So as the trainee shares their case presentation, it's transcribed in real time by an AI model. That transcription of the case is then processed and analyzed by a large language model that does several things. So it will summarize the case presentation. It will assess the case organization and give feedback on the structure of the presentation itself. And it will then attempt to detect the implicit or explicit presence of our thinking habits. So we ask it to look for those self-reflective questions that Sharon shared earlier, such as, does the story still fit the new findings, or is this what I expected? This heuristic gives us and the AI a multifaceted way to interpret the trainee's thinking, which accommodates the fact that AI is still imperfect and it still has a limited view into human thinking. I brought a physical prop today as an analogy, a crystal. And I like this idea of thinking about a problem and thinking about thinking as gazing into a prism that you turn in your hand. So as you turn it in your hand, you can notice the subtle changes in the refraction of light within. And I think that's what we're doing here with thinking and what we're asking the AI to do with the thinking of our trainees as well. So within a couple minutes, those analyses are completed and consolidated into a thinking habits report that's viewable on a device. So this report has a simple scoring system up at the top with those colored bars that tells you whether or not the AI detected the thinking habit in the trainee's case presentation. So green means it did, yellow means it maybe did, and red means it did not detect that thinking habit. And then it suggests prompts to acknowledge the trainee's strengths. So we always want to lead with strengths and acknowledge the good thinking that our trainees are doing. For instance, your presentation reflected a good grasp on the implications for a neonate with possible candidemia. How did considering the CSF results influence your clinical reasoning? The second question, and another thing that it does is generate coaching questions. So these are suggested questions that the attending can share with the trainee. For interpretation, you decided to order many tests. What did you expect the result to be? Or for solution, given the positive blood culture for Candida, what are the potential sources for infection in a neonate and how would you investigate them? That second question is all well and good, but as we know, the attending already shared her suspicion that Candida was not correct. And while current large language models do have an amazing grasp of medical knowledge, they're not doctors. So I like to think of the AI as a second brain or a teaching assistant that provides the attendings with a menu of coaching questions and feedback for their learners that they then decide how to use. That working relationship is designed to make sure that that human-to-human connection is strong and consistent by providing insights that have this shared language no matter the clinical environment. Over time, feedback from our users will help us refine those coaching questions that we generate. And finally, these thinking habits are assessed over time. So you can see that attendings can understand which thinking habits their trainees need to develop the most, and trainees can watch their thinking habits develop over time. So AI Click is powered by AI models. They're all hosted on Stanford Healthcare Secure GPT, which is safe for patient and learner data. We interact with these models via prompt engineering, which if you've never heard that term before, it's natural language writing that is just methodically honed to get the best and most consistent results. These prompts elaborate on the thinking habits matrix that we shared and describe what a good coaching question looks like, for example, and they can be thousands of words long. We've validated these prompts through an iterative writing process in which Sharon and Kathleen, as our subject matter experts, compare their notes and observations from case presentations with the AI analysis. So when we roll out the AI Click to our pilot study participants next week, their feedback will also help us improve that analysis. So it's always going to get better. That's our frame of mind here. And speaking of getting better, we are designing this as a model agnostic application that is intended to replace old models with new models as they become available. So for example, we started with OpenAI's GPT 3.5 a year and a half ago, and that became GPT 4, 4.0, and now we're using Google Gemini Flash 2.0 to power AI Click. So it's awesome that we get to benefit in real time from the race to develop the best large language model. And to tell you a little bit more about our product development, I'll hand the mic over to Peter.
Thanks, William. All right, I'm going to walk everyone through a peek behind the curtain of the back end. Surprise, all roads lead to REDCap. So for development, as part of the education technology team, we are under TDS, Technology and Digital Solutions, Research and Education Group. And so we were fortunate to be able to have access to developers from the Research Technology Applications Solutions team. And we understand that that's a huge bottleneck. It's having access to these development resources. So we were really glad that we were able to have that connection so that we can kick this off. For the actual product, as I had mentioned, everything was developed within REDCap because it uses Stanford, we connected it to Stanford Medicine Secure GPT, and we want to be HIPAA compliant. And so all the data, any of the transcripts or recordings that occur during these coaching sessions while using AI Click are stored within REDCap, super secure. And for updates, once again, if we need to make any changes to the type of model we're using, we go into REDCap and we switch that up. If we need to do any profile or security edits, we also go through REDCap and we collaborate with our developers and designers to make any of the user experience or user interface changes. So our learning design, surprise, surprise, is very education-centric. In kind of a realm of an oversaturation of AI-oriented tools, we wanted to make sure that we have this learning first philosophy and we stick to it. So our use of AI is meant to enhance, it's not meant to replace. And we want to really empower our users to leverage the human connection that you have from these coaching conversations and interactions. So this will help reduce cognitive load and also enrich these discussions that you're having with your learners. And last but not least, we want to empower our learners to empower their learners so that we have kind of this ripple effect in terms of how we make this larger impact with the different things that we're trying to teach and coach to everyone. So a quick overview of what AI Click does and doesn't do. We want to show that AI Click can focus on thinking habits for problem solving. And so it really explicitly emphasizes the coaching element of things. So providing the self-reflective questions to consider as you make patient care decisions really is an element that allows us to provide shared language between coach and learner so that they can use that consistently over time. And centering on the provider or the teacher-learner pair and augmenting the teacher really enhances the coaching skills that we so much emphasize. However, AI Click does not provide any solutions or knowledge, at least not in the traditional sense. It does not record any of the patient interactions, and it does not replace teaching or coaching in any capacity. On the contrary, we want to augment these critical learning exchanges.
Thank you, Peter. So next week, we're really excited about our study participants being able to use AI Click and see what AI Click can do. And we'll get feedback and data from them. And we're hoping to start up a second cohort who will co-create with us later in the year. In the future, we're really seeking longer term funding so we can continue this project. We're looking for internal Stanford support for future versions. And we're seeking any established attending trainee groups, small or big, who are willing to do this early piloting. We hope in the future, we envision a version 2 of this. And we also envision a general problem-solving thinking habits matrix and AI adaptation, because truly there are problems to solve in any field. So I and the rest of the AI Clinical Coach team want to thank you all for your engagement, for your attention. We hope that we showed you an AI tool, AI Clinical Coach, can actually enhance and help us humans think and train and learn better. And we hope, and we also thank our funders and our in-kind supporters, as you see on this particular slide. One last personal note, I and the rest of our AI Clinical Coach team feel this really deep responsibility to promote this idea of thinking habits, of cultivating this thinking mindset, so that we can all use knowledge and AI-generated knowledge critically and responsibly. Because then all of us can then have good thinking habits, and this will help us all make the best decisions for our patient. So thank you all, really appreciate it. If you're interested in joining us on this journey of cultivating a thinking mindset, you can scan that QR code. We also have physical THM cards. If you're interested in trying this out, I would suggest you try it out first on your own, and please give us feedback. So thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.